Okay, I think I'm going to start and people can come and join if there's any more waiting to join. So welcome everybody to our webinar today that's on introduction to an MSK approach on shoulder pain. This is a two-part webinar. Today is a two-part webinar and a seminar. So this is the first of the training that we're putting on today, which is an introduction level, and then we have a second happening later on, maybe in November time. That will be a more advanced session. Very grateful to Paul and Lucy, who have helped put this together and done all the background work, so I'll welcome them shortly. Just a few housekeeping bits before we start. So we will be asking you to evaluate the session, and we will be, because this is a webinar, slightly different style to our normal lives, because we really want people to interact and join in the conversation, discuss the different points, so the presenters are welcoming any kind of discussion. I think the session is split into 3 different sessions, and at the end of each little bit there'll be a chance to ask questions. Any questions throughout, if you just pop them in the chat or the Q&A box, I'm quite happy for people to unmute and turn their cameras on and ask their own questions. If you just put your hand up if you would like to ask a question, and we will acknowledge that you will let you speak, and you know, any kind of opinions and discussions are welcome. You know that we love for you to tweet us, so our Twitter handle is GMNISDN, and any future, I'll pop this link in the chat box as well, just to let you know of any further webinars that we've got on. Any other problems, please do email Karen. So without further ado, if I can introduce Paul and Lucy, and they can take it away, and will be the presenters for you today. Thank you for joining. I'll be back at the end.
Thanks, Faheen. So just a quick introduction. My name's Paul Barrett. I'm a consultant physio and have been since 2016. And this is Lucy.
Hi, I'm Lucy. I'm one of the upper limb clinical leads at Salford Royal in the MSK department.
So as Faheen said, it's like a 2-part training session. So this is about just covering the basics, trying to make your life easier, you know, quick wins and things to save you time clinically. It is MSK based, and we are no neuro experts or IT experts, and this is our first webinar, so bear with us if we have any IT issues. We welcome interaction. We're going to split it into a few sections. If people have questions, they can stick it in the chat, or we don't mind if you unmute and just ask the question out loud. We're going to have questions after the end of each section as well, so you could just store them up for that. So whatever works, really. So some of you may find it a bit basic, but what we want is everyone to have a good solid foundation for the next session. So if we just share our screen. Okay. So learning objectives for the day, having an awareness of common MSK pathologies and how they present, trying to make an assessment more structured and focused, understanding normal and abnormal movement of the shoulder, and then having an awareness of treatment modalities for common MSK pathologies, and then hopefully you can then relate that to your neurological patients. So the common shoulder pathologies, frozen shoulder, everyone's heard of that. Rotator cuff related pain, so this comes in various guises, so people might have known this as impingement or subacromial impingement. They're old words and we don't use them anymore. Subacromial pain syndrome is another one, and the more agreed term currently is rotator cuff related pain. We've got the rotator cuff tears, and we'll briefly touch on partial thickness and full thickness tears and degenerative and traumatic tears, and then also instability and labral tears. Obviously, this is only an hour and a half, so we're going to be tight on time. So we'll just give a brief overview of the prevalence, any current understanding on the pathophysiology, but really that's something you can read, so we'll spend very little time on it, and then we'll go and look at the assessment and treatments. So I hope everyone's happy with that, and that's what you're expecting. So frozen shoulder is a prevalence of 2 to 5% in the literature. A more recent study in the UK, it's a UK FROST trial. It's a multi-centred trial on frozen shoulder. In their introduction for the UK, they say that it's actually 1%. So there's obviously disagreement about that. It affects 1 in 12 men and 1 in 10 women, most commonly between 40 and 70 years of age. You can get idiopathic and also a secondary frozen shoulder, which can be post-traumatic, and secondary frozen shoulders also come on perhaps after cuff tears, and this is probably where frozen shoulders post-stroke come on as well in terms of that secondary bracket. So it often settles with time. Some papers say 1 to 3 years, but Hand et al. Showed that some patients experience symptoms at 6 years from onset. So if you do nothing, it generally gets better over time, but it lasts quite a long time. And then risk factors, so diabetes, thyroid disorders, rheumatoid arthritis, gout, hyperlipidemia, Parkinson's. So I said it was slightly in dispute, and that doesn't really stop. So no one really agrees on exactly what's happening. It has been found to start in the anterior structures. So if you think your anterior, so your middle cleanohumeral joint ligament, your anterior capsule, that's why you get that loss of external rotation. Some papers suggest there's an immune process, there's inflammatory process, and then also subsequent fibrosis, all playing a role in the pathophysiological process. And Bunker actually demonstrated fibroblasts moving into myofibroblasts, which is kind of similar to Dupuytren's contracture, which is like a progressive contracture. So frozen shoulder, although it's showing some characteristics of that, isn't truly like a Dupuytren's because it's not progressive and it does go back. But it's interesting that they've had these findings, but currently they think a lot of these things go on and they can't really decide exactly what the cause of it is. So I think this is the core of any kind of shoulder assessment. So your priority one is to check that your shoulder's not stiff. So if your shoulder is stiff, then if you do any tests for any other conditions, they're all going to have false positives. So you can save yourself a lot of time by just checking properly whether there's passive and active stiffness or not. And it's a really simple 10-second job that can actually save you doing a lot of other things, potentially doing provocative things that cause the patient's pain, and then you being led down the garden path. So so basically it's determining whether the joint is stiff. So external rotation, like I said, anterior structures are more affected. Can everyone see us or not? Or can you just see our presentation?
We can see you as well.
Yeah, okay. So we'll just do like a demonstration with this, I think. And if you're with others on this presentation, you can practice as well. But in terms of external rotation, what we would do is basically when you externally rotate, you get cleanohumeral joint movement. And then when people reach their limit, they then get their scapular retraction. So what we're interested in a frozen shoulder is the glenohumeral joint. So it's really important that you take out scapular movement. So with your lateral rotation, you get them to do it to see how willing they are to do it. And then it's as simple as standing by their side, supporting their arm and bringing it out until you start to feel that stiffness, and then comparing it to the other side. So remember, everyone's different and you need to get that person's normal. Abduction is, again, a really straightforward thing to do, and numerous people come and speak to me about patients, and they say to me, right, it's got 140 degrees of passive abduction, and I immediately switch off because that information is not correct, because it's impossible. So it says to me that they're not assessing the patient properly. So your glenohumeral joint basically doesn't involve scapular movement because that's where the glenoid is. So you make sure that scapula doesn't move, and as you can see with Lucy here, and Lucy is quite mobile, I would say that's just over 100 degrees, and she can't go any further because the acromion is stopping the humerus from moving, basically. So so really 90 degrees, 100 degrees, and then you can start to see that the scapula's starting to move about there. Yeah, so those two movements are really quick to do and give you a lot of information. So
Paul,
yeah,
we've just got a hand up.
Yeah.
Joe has popped a hand up.
Yep.
Would you like to come on, Joe? Oh, sorry, Paul. I think Joe, have you got your hand up? Is there a question or? Okay, Karen, can you allow Joe to speak, please? It's saying the mic is disabled.
Joe, you'll be able to unmute it yourself now.
Thanks, Karen.
Hi, Joe. If you've got a question.
Oh, it's still saying it's disabled. Okay. It was just, I think Joe was just saying that she can't see you, but everybody else, I think, is able to see you in the presentation. That was all.
Okay.
That's fine. Sorry, Paul, carry on.
Okay. And then internal rotation as well. Self-explanatory, isn't it? Putting your hand behind your back. And often what we do, you've got to bear in mind they might not have abduction, but you often just see how far down the arm can drop, but you might need to modify that. And sometimes I don't do that because of the restriction. So if they've got that restriction, there's no point doing anything else, because until that stiffness is treated, everything else is going to be misleading. Obviously, there are caveats to that in terms of if you're suspecting serious pathologies, etc. But for normal routine patients, that would be our go-to first thing to do with the patient. So we're going to treating the stiffness in a minute. So if there isn't restriction, then you're saying that it's not a stiffness predominant frozen shoulder. So it could be a pain predominant frozen shoulder. So there's different ways of looking at a frozen shoulder. Some people say it's freezing, frozen, thawing. Others propose a pain predominant and a stiffness predominant model. So a pain predominant model is much more difficult. I don't believe that any clinician can accurately and confidently say that it's a pain predominant frozen shoulder and not a rotator cuff related pain. I've probably backed the wrong horse, but before, and then it turns out to be a frozen shoulder, and then likewise the other way. So they both present very, very similarly in the early stages. So if it's not stiff, then it could be pain predominant, but then you also need to start looking at other diagnoses. You know, frozen shoulders often have night pain. They often have pain with movement, and so it could be more osteonecrosis, that type of thing. So you just need to have those things in the back of your mind. So if it isn't stiff, you need to prevent the stiffness. So just thinking about your patients, if their arm is less mobile, example from an MSK background is that if you've got a degenerative cuff tear and they've not been moving it because the muscle's not been working, then that movement then gets stiff. Yeah, so it's about preventing stiffness, because if you get stiffness, then everything else has to stop until you sort out that stiffness. So avoid immobilization where possible, and particularly if they've got risk factors for frozen shoulders, and regular exercise to maintain range of movement. So that's a really quick way of doing two things to then work out whether it's stiff or not, and whether you should spend time looking at other things. So common question, so can a lax shoulder become a frozen shoulder? So yes, it can. So nothing is immune from developing into a frozen shoulder, and just because it's been lax doesn't mean it can't then be stiff. If a patient has a cuff tear, like I've mentioned, and a frozen shoulder, which takes priority? Well, if it's of a surgical age, the cuff tear and it's traumatic, then they're not going to operate until that stiffness is sorted out, and there's a good reason for that. So so stiffness always takes priority. If a patient has a stiff shoulder, I mentioned before, any kind of provocative test for, say, rotator cuff related pain. I'm sure people have heard of the empty can test, for example. So you basically put your arm out in scapular plane and then empty the can out, so medial rotation, yeah, and then you resist that pressure. So one of the movements we lose is internal rotation, which is what you need to do to get into the position. So as soon as you do that, you're going to cause pain. So the pain's coming from the capsule and the stiffness, but it will be telling you positively that it's causing the shoulder pain that could be related to rotator cuff related pain. So the most important thing with frozen shoulder is history, restriction of active and passive movement. So it's the most simple thing to do, and it can be done in, you know, if you do it regularly, it can be done in 10 seconds flat. A lot of the guidelines do require a normal x-ray. If you actually then unpick all of those guidelines, they all state you need to do it for different reasons. So some say you need to do it because you need to differentiate between OA and frozen shoulder. I'd argue that the treatments are all the same, so it's not going to change what you do to the patient, therefore you don't need to do it. Some people, some guidelines say that you're doing it to exclude other pathologies such as AVN, so avascular necrosis or osteonecrosis. But we know that stage 1 osteonecrosis doesn't show on an x-ray. So if you're thinking it's that, maybe that's not the right modality to use, because a normal x-ray is going to then give you a false reassurance. Similarly, if you're talking about secondary tumours, so bony mets, again, up to 50% destruction before it shows on an x-ray. So again, that's going to falsely reassure you. So it has its place, but there's no consistency or agreement in terms of the rationale behind why they're on each of the guidelines. Masqueraders, so secondaries, so lungs really common, breast is really common, and non-Hodgkin lymphoma is really common. I've seen one recently that was a lymphoma presented as a barn door frozen shoulder. So they do come about, primary tumours obviously, and then just being more aware of the inflammatory things, so polymyalgia rheumatica, RA. So
So moving on to treatment. So there's quite a lot that we can do treatment-wise for frozen shoulders. So I always kind of think, so always encourage self-management. Often steroid injections can be useful and have its place. They can really massively help to kind of reduce the period of a frozen shoulder, and can be really helpful in like the pain predominant stage of frozen shoulders, because the injection can help to control that pain, calm it down, which will allow patients to be able to sleep a bit better, will help with mood, and then enable them to engage with their rehab. Mostly physiotherapy, and rarely surgery is needed. And it's really important that, you know, we explain to patients that unfortunately there is no pain-free way out of a frozen shoulder. No matter which treatment route we go down, it is going to be sore, but it's just important to give them like lots of reassurance, to know that this is normal and this is what we need to do to try and help get them better. So in terms of exercise, I'm going to go into some more specific exercise bits in a second. So I'll leave that for a moment. But other things treatment-wise is like lifestyle. So encouraging like a healthy, balanced diet, and weight management. There is some research that shows that people who, you know, are overweight, it does cause like an underlying low level of inflammation in the body. So Paul said earlier that there is a potential inflammatory component with frozen shoulder, so weight management is important. There's also a strong link with diabetes in frozen shoulders, so ensuring that diabetes is well controlled. And anxiety and stress management. So when people have like the pain predominant frozen shoulders, it can be quite distressing if they're not sleeping, able to function in constant pain. So encouraging like mindfulness, stress relaxation as well. So if somebody's really struggling with the exercise or pain, we can then potentially look at like the corticosteroid injections, which can be done to enable to help people to kind of exercise. The next stage after that, if people were struggling, would be a hydrodistension. So this is where they basically they basically blast like a high volume of saline into the capsule to basically rupture it, and distend the capsule to stretch it basically, followed by anesthetic and steroid as well. If people have exhausted like the exercise, the injections, hydrodistension, and they're still really struggling, the last kind of treatment would be like a capsular release, but that usually wouldn't be considered until all conservative management has been exhausted. There are poorer outcomes with people that have comorbidities. And yeah.
So diabetics are twice as likely to have a frozen shoulder than non-diabetics. So certainly on the treatment algorithm, we have a lower threshold for injecting diabetics, but when injecting someone, you then need to think about the consequence of that. So it can affect their diabetic control. So if their HbA1c is over 75, then there's quite an increased risk of joint infection. So we don't really inject anyone with HbA1c over 75, and the lower the better really for control and risk. Obviously there's risks of immunosuppression as well, but certainly steroid injections, much lower threshold to do that earlier in diabetics. And I actually have quite a low threshold for injecting anyone with a frozen shoulder, which has significant pain, because I do think that doing that early reduces the duration of the condition. In terms of landmark guided versus ultrasound guided injections, there's no evidence to support guided injections. They don't have any improvement in outcome, and they cost more and you have to wait longer. So yeah, and in terms of hydrodistension, the more contracture there is, the more challenging it is. So they do better with less contracture, and also diabetics don't do as well with that either. But having said that, some diabetics do well with it. So you just need to bear that in mind in the consent process.
Mm-hmm. And then moving on to like specific treatment at each stage. So as Paul said, we tend to kind of split frozen shoulders into the pain predominant or the stiffness predominant frozen shoulder. So in terms of the pain predominant ones, the main key really is giving lots and lots of advice and reassurance to increase self-efficacy, encourage lots of self-management, including those lifestyle modifications that we discussed. And I'll go on to specific exercises in a moment. And then the consideration of a steroid injection to enable them to engage with rehab. In terms of the stiff predominant shoulders, so again, it would be to continue to support self-management and kind of up that physio a little bit, really. So there is some debates regarding the treatment around static stretching versus heavy, slow eccentric loading. So a fairly recent study looked at they were in support for heavy, slow eccentric loading. So as an example, you could get somebody lay supine, get them holding a weight and nice and slowly work on that eccentric external rotation, use the other arm to bring it up. And they found that they had quite good benefits with that. In terms of dosage, they would advise like 3 sets of 5 to 8 reps frequently, so like 2 to 3 times a week. However, in practice, if I'm being honest, I generally tend to find that the static stretching does quite well. It's often in this study, they advise that, you know, with the static stretching, you cannot lengthen the tissues and that you would basically have to do it really, really frequently. However, in practice, I generally find that people still do quite well with stretching, and then can then go on to the heavy, low eccentric loading. So there's no right or wrong there. It's just different approaches. And then in terms of like analgesic ladder, so we'd always want to try like the least invasive option first. So we wouldn't just go straight for, you know, a capsular release. We'd want to try like making sure that the patient is taking pain relief regularly, using ice heat if needed. And then we can kind of work up that ladder in terms of steroid injection, capsular release if needed. In terms of the stiff shoulder then, so manual therapy is definitely something that has its place. It's really important to know that manual therapy shouldn't be used as just a standalone treatment. It needs to be in conjunction with quite a comprehensive rehab programme. There's a study that looked at like manual therapy, and they found that the force that was needed to kind of deform the like joint capsule is like significantly heavier than like any human could kind of perform an immobilization. So they found like that the maximum force that a therapist could use during immobilization was like 21 kilograms. And to deform the capsule, you'd need significantly more force than that. So I think manual therapy is really good to help encourage people to feel safe to move. And there's a lot of great feedback from like that tactile feedback. They feel that they're, you know, got the confidence to move. And sometimes I may do like a little bit of soft manual therapy at the like soft tissue massage at the posterior cuff, or do some higher grade mobilizations into abduction like this picture shows. But it's just to make sure you're not doing it as a standalone treatment. And then again, supervised exercise and lots of reassurance.
And I would say that it's doing these exercises hurt, so that if you give them to the patients and then they go home and do them, they then are worried that they're going to do themselves harm, and are they doing it right? So I go through it with them, explain that it will be painful, it needs to be tolerable, but and you should see an immediate change in their comfort of movement. So I get them to do something, rate it out of 10, just do one stretch, and then retest it, and they will feel like it's looser, or the pain won't be coming on quite as early. So you do get that immediate change. So that's quite useful for you, because if you've got that frozen shoulder, if you're doing the right exercise for that person, you should see fairly quick change.
Mm-hmm.
In terms of temporary symptoms. Yeah,
absolutely.
It'll take a long time to actually get better. Yeah.
And then just some examples in terms of stiff shoulder exercises. So ideally we want to focus on like more the passive stretches to help with this. So I try and encourage give people exercises that they can manage and easily build into their daily routine to make it a little bit easier for them to manage. So if you think of the main movements that we want to work on is like flexion, abduction, external rotation and internal rotation. So for example, the one in the middle where that lady's holding the stick and like kind of passively like pushing out into external rotation, that will help with that. You've got the chap that's on the table like moving forward with the towel, so you can do some table slides or even have your hands on the table, get them to stand or in a chair and kind of slide back, so you do like a table walkway, so that will help with flexion. The chap that's got his arm resting on the plinth, so it's kind of a variation of like a sleeper stretch, I guess, isn't it, where you're going to work on that internal rotation to stretch out the posterior capsule. Some other ideas, if they're laid down in bed, you could maybe ask them to use their other arm to help take up into flexion, or even use like the stick to take them out into abduction as well. So there's lots and lots of stretches that you can do, but I just found some pictures of the ones that we would commonly give. Yeah.
So the take-home messages with that really are abduction, external rotation are the key movements, plus perhaps internal rotation.
Yeah.
Do it actively, then check it passively, making sure the scapula doesn't move. And if it's stiff, treat the stiffness. If it's not stiff, then consider a pain predominant frozen shoulder, or look at other diagnoses.
Yeah. And in terms of reps and sets, I would just generally say it obviously depends on the patient and their ability and pain levels. But I would just say really regularly throughout the day if they can, like every few hours, just build it into their routine. So say if they're watching TV and the adverts come on, that might be a little bit of a prompt to kind of they can just rest their arm on the end of the sofa and just do a bit of a stretch there. Or, if they're in the kitchen waiting for the kettle to boil, could just do some of like your table walkaways at the kitchen counter, obviously depending on patient's ability.
Yeah.
Yeah.
And fairly low threshold for injecting if pain's a big problem and you're confident it's a frozen shoulder, because that will then enable the patient and you to move them forward quicker.
Yeah. So that's kind of like a quick run through of frozen shoulders. Do you have any questions regarding frozen shoulders before we move on to rotator cuff related pain?
No questions. Okay. So we're going to spend more time on this. So rotator cuff related pain and frozen shoulders are by far the most common shoulder pathologies. So there's a lot more to it. So again, we're just going to have a brief overview, talk about the brief history of it, and then we'll start trying to move into more kind of assessment, because like I say, this involves the scapula. There's a lot of muscles on the scapula. It involves a glenohumeral joint, and so one of my key things with shoulders is that when I was at band 5, or we used to be called juniors, everyone made them sound so complicated, and when I actually started to understand them, I started thinking, well, actually these aren't complicated, they're simple. And my main motto with a shoulder is keep it simple. And I just feel on reflection that those people that said making it sound complicated were just basically making themselves sound clever, and it's not complicated. So you can break it down really simply, and the majority of people will respond to a few basic things, so you can get the large proportion of people better doing fairly basic treatments. So rotator cuff related pain, otherwise known as subacromial pain or SAPS, or words that I've banned, such as shoulder impingement. So it's the most common shoulder complaint, up to 70%. Annual prevalence estimated at 7%, which increases with age. Risk factors, so again, you've got metabolic syndrome, your diabetes, cholesterol, thyroid, inflammatory conditions, smoking. It does encompass a number of things, so tendinopathy, calcific tendinopathy or tendonitis, bursitis. So a lot of people still cling on to that bursitis as well. My personal view on a bursitis is that it's a component of a tendinopathy. It's not the reason. It's a kind of secondary effect of something else that's going on. The history of it, well, impingement is what a lot of people used to call it, and you used to think that as you lifted your arm up, you kind of hit the tendon on the underside of the acromion, and then came the subacromial decompression to give it more space, and they took away the bursa as well, and then they did a lot of scans, and then they started to realize that actually there was no pathology on the bursal side of the rotator cuff, so it can't have been hitting anything, and a lot of the changes were actually on the articular side. So how are these changes on the tendon coming on the articular side? So these are these intrinsic theories where the humeral head's migrating superiorly, putting different forces on the tendon, leading to tendon degeneration / tearing. Some people then proposed more of a vascular changes through the tendinopathy, and then it kind of developed further into saying, well, there's a lot of tensile forces, and if you think about the rotator cuff, they work together. You can't really isolate them. All of the tendons merge into the capsule, the ligaments merge into the capsule, so it all becomes one. Basically any kind of force, so if your subscap and infraspinatus are angled at 45 degrees and they control the translation superiorly and inferiorly of your clean humeral joint, so if they don't activate quick enough, it's not centered into the socket, therefore there's much more strain going through the tendons, and that's that eccentric tension imposed on the rotator cuff. So that's the whistle stop tour of the history of it. So history is key. So they often have pain putting the hand behind their back, but often it's not particularly restricted, or it could be a little bit. There's one study that looked at pressure inside the subacromial space. So putting your hand behind your back, I think that doubled the subacromial space, and then full external rotation halved it. So there's a big difference in pressure within that compartment. So often a painful arc between 60 and 120 degrees. What you can find, you can get some secondary stiffness with things like this, but it's really important in the examination. The first thing to do, just like a frozen shoulder, exclude stiffness. If there is a lot of significant restriction, then it's going to affect your tests. If you've got restriction of medial rotation actively and passively, then there's no point doing any provocative test that involves medial rotation, because it's going to be painful and not tell you anything. So this can really inform what you can miss out, and it saves you a lot of time and saves the patient a lot of pain as well. So you're possibly looking at pain inhibition, and we'll come on to improvement tests later, but I've seen papers that have shown that facilitating your rotator cuff then improves your scapular-thoracic movement. So they're all integrated and linked together, and it's very difficult to split them up. We talked about rotator cuff strength testing. It's very difficult to isolate any muscle in the shoulder. So if you actually read all the literature and pick it apart, it says that this test is useless, this one's useless, this one's useless, and you start thinking, what on earth am I doing? And it then becomes apparent that all those papers are looking at things in isolation, and then using clusters of tests is actually much better. So if you had a test that has high specificity and a test that had high sensitivity, so i.e. one with a low number of false positives and one with a low number of false negatives, then if they're in agreement, you're much more confident to say that they have that problem, if that makes sense. So so we've got special tests. So there's things like empty can tests. So that's basically scapular plane, emptying the can out and then basically resisting that pressure. We've got Hawkins-Kennedy test, which is in front, and then you're putting them into medial rotation. The idea of that is that you're moving all the structures up into that coracoacromial ligament. That's not nice. Patients don't like it. So there's a variety of tests. How useful they are, no one test can tell you that they've got, you know, rotator cuff related pain. And the more recent thing, well, that's been around for quite a while, is improvement tests. And some people like everything, some people don't like them. I actually think they've got quite good value because they can actually guide what to do. So yeah, just briefly before we move on, so you got your different cuff tears. So you've got full thickness cuff tears, you might have seen them on scan reports, and then you get partial thickness tears. So a full thickness tear is basically a hole straight through the tendon from top to bottom. Your partial thickness tears are like exactly that. Just a little nick in the tendon, often on one side. So if you imagine, I wouldn't say this to patients, but if you imagine like a rope that's fraying, it's basically just fraying of the tendon. So it is really quite common. And so if we're thinking, right, well, have they got this? Do I need to scan them? So you don't need. So in terms of imaging for subacromial pain or rotator cuff related pain, unless you're suspecting a calcific tendon, which pretty much has a very acute onset, very severe pain, can present like a cuff tear, can have weakness, but without trauma, and it's more painful pre-calcific and post-calcific, then you might x-ray it. But other than that, x-rays aren't first line for any kind of rotator cuff related pain. In terms of your tendon tears, so if someone has cuff weakness and they're 75 and they're not physiologically particularly healthy, and they've not done anything to cause the trauma, then by putting all those things together, you can then realise that that tear has been a low force tear. Therefore, it's not going to be a surgical candidate, because if you put a stitch through it, it rips through it like cheese wire. So these are these degenerative tears, and there really isn't much benefit in investigating them because they're weak. The tendon quality is not great, and surgery is not an option for them. Therefore, treat them. By investigating it, you delay their treatment. Obviously, for full thickness traumatic tears, particularly in the people of good physiological age, times of the essence with acute traumatic tears, so they do need investigating quickly. And if you are going to image it, then so what? You'd need to know quite a number of things. So you'd need to know about partial thickness tears, and I'm just quickly trying to find this. So there's a study done in 2022 looking at an area of the UK, and they found that 22% of the population had partial thickness tears. No, sorry, full thickness tears. And of that 22%, 48 point something % of them were asymptomatic. So pretty much 10% of the normal population in that area of the UK had a full thickness cuff tear without symptoms and were just walking around having a normal life. So when you do investigate something, how do you know that it's relevant? And that's where the history is really key. In terms of the partial thickness tears, I'm still trying to find the study for you.
I think it was 13%.
There it is. So 13 to 32% of the population, this is a study from 2019, had partial thickness tears, asymptomatic. So this is just part of an aging continuum. It's like when you see degenerative disc disease on a scan, it's like, so what? A lot of, over 30% of 20-year-olds have degenerative change in their disc. It's part of a normal process. So we need to be careful not to label things as abnormal when they're possibly not. So that's just a whistle-stop tour of the role of imaging for those tears.
So in terms of like muscle testing, so as Paul spoken about, like tears, these are the tests that we would kind of usually do to test the integrity of these muscles. And as Paul said, you can't isolate any of these muscles, but you can bias them a little bit more with these specific tests. So in terms of supraspinatus, so Paul's kind of spoken about the full cam position. We generally tend to find that anyone with a painful shoulder it's going to be sore in that position. So to get a more accurate kind of to be able to test supraspinatus in hopefully in a less painful way, would usually take them into kind of like scapular planar abduction around 20 to 60 degrees of the full cam position, and I would usually kind of feel into the supraspinatus fossa where the supraspinatus sits, and then ask the patient to gently start kind of resisting me. And then what I'm wanting to feel is that muscle kind of switching on beneath my fingers. Are they significantly weak? That may indicate a bit of a tear going on there. In terms of like infraspinatus, so ideally we want them slightly in about 10 degrees of abduction, and I'm going to put like my thumb and finger into kind of like the posterior cuff area, and then again ask the patient to slowly start resisting me. Yeah, so the reason we're taking them into 10 degrees abduction is the EMG studies show that when you take them into about 10 degrees abduction, it helps to switch off deltoid a little bit more, so it biases infraspinatus a little bit better. So again, another positive test would be if there's significant like weakness there. Sometimes they may be weak because of pain inhibition. So sometimes you can kind of unload them. So by kind of putting my like fist under the shoulder to try and offload the shoulder and then resist and see if that helps. If they're a bit stronger, it's slightly pain inhibition, or if it's the same, it's slightly true weakness. And then subscapularis, we can do the bear hug test. So patient puts their hand onto the opposite shoulder, usually around 45 degrees. You can do it at 90, but that can feel a bit too uncomfortable for patients. And I basically just put my hand under their hand and ask them to not let me kind of lift off. So that's testing your subscapularis. There are a few different tests for each one. So for subscapularis, you may have also heard like lift off or belly press. The EMG study showed that basically that with the bear hug test, you get the same amount of activation as subscapularis compared to those other tests, but with less contribution from like teres major, lat dorsi, and your pecs. So it again helps to bias subscap a little bit better. Yeah.
And again, when you do these, it's just accepting that this is the best information that we have to make it as specific as possible, knowing that it's still not particularly specific.
Yeah.
And we're just building a picture. It's more jigsaw puzzle, isn't it?
Yeah.
Yeah.
So you're taking into account like the history, what they're telling you, and then kind of adding to that, aren't you, to try and help build the picture. Yeah. So in terms of like, we're going to do a little bit of a practical here. So we just wanted to kind of, if you are in pairs, I don't know if you're at home with anybody, but just maybe try and practice kind of like looking at the bony landmarks. Do you want to do it on me?
Yeah. Yeah. So I'm I'm probably teaching you to suck eggs
Yeah.
here, aren't I? So in terms of your long-headed biceps, so it's quite easy to locate. I just rest my finger over the top and you just externally rotate and you can feel the greater tuberosity and then the lesser tuberosity, and there's a dip in the middle. So that is the bicipital groove. Sometimes you see ultrasound scans that say the subscapularis is intact, but the long-headed biceps is dislocated. So that is actually impossible because subscap, there's some slips of it that go over the groove. So that person had a cuff tear that hadn't been seen on the ultrasound scan, and your long-headed biceps comes up and then attaches onto the top of the glenoid and the labrum. So that's long-headed biceps. Obviously the acromion is very easy. We talked about morphology. They used to have different positions. I don't pay much attention to it personally. Some people might. In terms of injections for subacromial pain or rotator cuff related pain, there are different approaches. You can go in the side, you can go in the back. I was taught to go in the side. I now go in the back because actually, if you think about what's there, you're much more likely to hit tendons. So I go in the back and aim up. You've got your AC joint here. So if you follow your clavicle around, that lump there, that's where the clavicle meets the acromion, and that joint, it's angled at about 45 degrees. So if you're injecting it, that's kind of the angle you need for your needle. You've obviously got your SC joint here. That can swell with degenerative problems, but anything around here makes me very, very twitchy. And I'd always have a low threshold for investigating any pathology around the SC joint, inflammatory, infective, sinister. So you've got your spine of scapula. You've got your supraspinous fossa just above there, so that's where your supraspinatus sits. You've got your spine of the scapula there. You've got your medial border down here, and that's often roughly in line, slightly angled to your spine. You've got your inferior angle here, and what else do we need to tell you? Infraspinatus there, so any kind of suprascapular nerve palsy, you often see wasting of these muscles. As you know, the innervation, it comes through and through the notch in the scapula there. If you ever get a winging scapula, so this is something that I think's incorrectly used a lot. A true winging scapula wings, it really sticks out, and it's because serratus anterior isn't getting the messages because of the long thoracic nerve, and so you basically put your hands on the wall, push, put your weight against it, and this just swings, symmetrical as well. So a winging scapula is really obvious. So that's rough palpation. Yeah. Are you wanting to go and do that, or are you happy with that? Obviously, you've got your coracoid process here as well.
Okay.
No, okay, we'll move on then.
So in terms of like normal scapulohumeral rhythm, so the scapulohumeral rhythm basically means looking at the scapula moving on the thorax and the humerus moving within the glenoid, and they work together so we can achieve full glenohumeral joint elevation. So what happens is the scapula rotates on the thorax, so it externally rotates and posteriorly tilts, which basically changes the angle of the glenoid fossa, allowing us to move the arm upwards. So any disturbance in this pattern will basically cause an abnormal scapulohumeral rhythm. So we've kind of spoken about like the bony structures there, and we're going to go more onto abnormal rhythm in a second. So looking at like what the muscles are doing. So when we abduct in the scapular plane, There's 4 main muscles that generally tend to control this movement. So the supraspinatus, which is one of the rotator cuff muscles, is the primary muscle for abduction in the arm to about 15 degrees. From there, the deltoid controls abduction from about 15 to 90 degrees. And then the force couple, so that basically means the muscles kind of working together, are the trapezius and serratus anterior. So they work together to coordinate the movement from like 90 degrees upwards. So then moving on to abnormal movement. So like what Paul just mentioned then, this picture here, that would be quite a significant cause for an scapular abnormal rhythm. So this is an example of like a long thoracic nerve palsy where that nerve innervates serratus anterior. So if there's any disruption in the signals, whether it be, it's quite well reported in the literature that it can be linked to like post-vaccination or viral infections, or any kind of thoracic or auxiliary surgery can cause any disruption to the long thoracic nerve, which can cause this. So you basically get complete medial border winging off the scapula. So this is quite an extreme example, but just to show you. But there's quite a few other causes for abnormal rhythm. So this could be bony, such as like thoracic kyphosis, joint, neurological, inflexibility. So as an example, if you've got any kind of significant tightness in the posterior capsule, or any kind of muscle stiffness around the area, it can cause translation anteriorly of the humeral head, which can create what we call GERD. So it's glenohumeral internal rotation deficit, where you'd compare kind of both sides, and you kind of look at the degrees of like internal rotation in 90 degrees abduction and compare it to the other side.
And you just check in about the scapula. So
Yeah.
you get to a certain point, and I don't know if you saw my scapula started to protract there. So it's making sure that you note that.
Yeah.
And then your question then is, why is it doing that? So is it true stiffness, or is it so inert structures, or is it because of contractile structures? So muscle stiffness can also cause restriction.
Yeah.
And a quick way that we do of managing that. So if you look at me, so look at the GERD. Okay, so yeah, just relax it a second. So if you look at the angle of that, what would you say that is? 50 degrees. Yeah. Then if we facilitate the posterior cuff, so if you facilitate me through yeah. So if we then just,
oh, right, I see what you mean.
So what we're just doing is there's evidence to show that putting pressure on the back of the hand does facilitate the cuff, and we're basically moving the posterior cuff from short to long, with some tension through it, through a full range of movement. If you then retest it,
so it gets a lot further.
Can you see I'm going further? So immediately, if you can see that, so immediately we know from that quick test that the restriction is not inert. So there's no point stretching it, because it's not a problem that needs stretching. It's muscle stiffness, so that muscle's hanging on. So that muscle just needs activation, and so proprioceptive bombardment can really just switch it on and be really useful.
Yeah, and then just lastly in regards to that, so muscular, so we briefly touched on the muscles then, but there's research that shows that with patients with SAPS, they can have basically alterations in activation of the timing of like when the muscles are activating and switching on. So they found that a common finding in SAPS patients was that they had reduced activation in serratus anterior and the rotator cuff, and actually increased activation of the upper traps. So this basically contributes to the loss of the posterior tilt and upward rotation of the scapula, which can then result in that abnormal pattern. Yeah. And then just moving on to like the improvement test that Paul kind of briefly talked about. So when I see an MSK shoulder, one of the first things I want to know is, can I change their symptoms? Like, have they got rehab potential? So the thing with the improvement test is that like with most things in physio, the understanding around these tests is still a little bit unclear, but there's a lot of evidence to show that the improvement tests that we'll go through in a second, if they change the patient's symptoms in that session, they've got an 85% chance of doing well with rehab. And I usually tell the patients that. So with any non-stiff shoulder, I tend to do these improvement tests with them, and it can really help to get the patient on board and build the trust with the clinician, because if you can change their symptoms in that session, they're more likely to be on board with what you're telling them to do. So just as a quick little task, the first improvement test is basically just about posture, really. So if everybody at home, just if you're sitting down, kind of slouch down for me like this. And what I want you to practice is, I want you to see how high you can kind of get your arms up in that kind of slouch position. So you can see his arms are literally kind of restricted here, and come back down for me. So if we simply just ask the patient, I usually say, imagine you've got a big helium balloon pulling you up to the ceiling, so you're just going to grow a little bit taller, okay? And then Paul, can you lift your arms all the way up for me? So you can see how much higher his arms go. I don't know if you felt that yourselves, yeah? So by slouching, I was just trying to think with your patients maybe on the wards, if they, if they've maybe had a stroke or some kind of neurological problem, and they're maybe sitting down slouched all day for a long period of time. When we're slouching like this, it can basically change the order of muscle recruitment, and the scapula and cuff have to work harder to function. So the research shows you can get quite tight in your pecs, you can get weakness in your deep neck flexors, increased thoracic kyphosis. So that awareness of posture is one really nice way to see if we can improve the range or strength.
And when you're going to do things with them, and I'm sure this is common through neuro rehab actually, start in that good position, and if you start in that good position, they've got the best chance of getting the most out of whatever you're going to do with them. I'm pretty sure you will do that anyway. But just confirms you're doing what we do as well.
The second improvement test is called the scapular assistance test. So this, with the scapular assistance test, it's basically it basically helps to encourage the normal scapular rhythm. So we're encouraging the posterior tilt of the scapula and the upward rotation. So we're kind of doing the job of the serratus anterior and the trapezius. Do you want to do it on me? Or?
Yeah, you can do it. Yeah, okay then.
Yeah.
So it's important, if you think about the workbooks, I'm just going to turn you around a bit.
That way.
Yeah, around that way. That's it. So if you think about the if you've got an upward rotation, that's that movement. Okay, so what things need to happen to move it up that way? So upper traps needs to work. Your serratus anterior, which comes through here underneath the scapula, that needs to pull round that way. So as this swings round like that, one of the most, so upper traps gets a bad name, and often it's actually levator scapula that's the culprit, because if you could getting a lot of tightness in there, as you swing round, it's going to stop your top corner here from dropping down, and then that also affects the recruitment. So actually, the other thing actually that's happening, you've got that posterior tilt as well as part of the scapular assistance test. So that requires length at the front, so your pec minor. It also requires some serratus anterior, and also if you think about your lower traps here, so those are the muscles that are working there. So you ask the patient to abduct in a scapular plane, like that, and I get them to rate their symptoms out of 10. As they then go again, I put pressure on it. So you're doing a bit of a posterior tilt, and also just pushing that inferior angle of scapula, and what you should find is an immediate reduction in their symptoms with that same movement.
And they did also find that through some MRI studies that when we do this test, because we're facilitating that posterior tilt, it does actually help to open up the subacromial space. So that may be why it helps.
And I know everyone works differently. Me and Lucy even do things differently. But if you know what muscles do that movement, and then that movement improves your symptoms, then logic says that focus on those muscles that do that movement or that prevent that movement. So if left scap is overactive, stiff, you know, if it's tight, you're going to massage it, you might try and stretch it. If it is overactive, that means that we need to get upper traps working better. So do some facilitation work on upper traps, serrated anterior. And like I said right at the beginning, there can be a number of different problems that are the underlying cause. But my belief, rightly or wrongly, is that if you give someone a serrated anterior exercise, if you give them a cuff exercise to facilitate the cuff, then those exercises are probably suitable for every single patient and will help get them better. So, you know, even if you're unsure exactly where you're going with it, doing those things should show improvement in my experience.
Yeah, I
for
agree.
90% of patients anyway.
Yeah. And then just a couple of others that we do. So you can combine these next few together. So when we like flex the shoulder with a straight arm, instead, if that causes the patient pain, you can instead you can ask them to kind of elevate with a short arm instead. So kind of punch up to the ceiling. So this basically helps to reduce the load on the shoulder. Yeah, so it basically helps to reduce the load on the shoulder, which will enable like the rotator cuff and the serrated anterior to activate a bit easier. Yeah, and you can combine that with cuff activation. So like what we did a little bit earlier with Paul, where we kind of facilitated to cuff. So you can either apply like that external pressure resistance, or you can get the patient to squeeze the fists. So I would say, okay, instead of elevating with a straight arm, can you punch up to the ceiling, squeezing your fist? Does that feel any better, worse? Most of the patients that I see would say that feels better. So then that's going to help us guide our treatment, which we'll go on to in a second. And you can also make this in MSK to push it even more. You can get the glutes involved as well. So there is research that shows like when we step or squat whilst doing some shoulder work, it helps to activate the glutes, which actually helps to kind of reduce any kind of activation through the lats, which commonly compensates for shoulder problems. So it actually helps to activate the posterior cuff better. So in MSK, if that's not really helping, I'll say, right, okay, I'll get them to stand and I'll get them to step whilst punching with a short lever and a bit of resistance as well. Yeah. So how do the improvement tests guide our treatment? So if we can get people better with these tests, and that's amazing, and I say, you know, I've just changed your symptoms, I know that we can get you better, so I'm going to give you an exercise to basically replicate what we've just done, which should help. So some examples that we may do is you may get a bit of resistance band around the back of their forearms. For patients that you may be seeing, if they're sitting, for example, you could get them kind of punching up to the ceiling with a bit of TheraBand around the back of the fist, or squeeze like a water bottle or something, you know, just to get that cuff activation. And then with our patients that have the ability to kind of step or squat, sometimes I'll get them doing like a squat on the wall. So as they squat down, they punch up to the ceiling, or I get them kind of lunging and punching. So you can kind of change it depending on the ability of the patient.
And then higher level things as well for the cuff. There's things called bushwhackers. I don't know if you do that. So it's like yellow TheraBand, and you're basically just doing this all the time with the band attached over there. So you're doing kind of high velocity work, because it is low level. So the cuff works at low level. So any kind of significant resistance is just going to make your big muscles work, and you're going to lose the benefit.
Yeah, so sometimes it's actually best to start with like the lighter coloured TheraBands, like your yellow and red, because sometimes if you know, we find like with our patients that are gym goers, they want that heavier TheraBand, but actually then the pecs and the lats just switch on and do all the work. So I usually encourage them to start with a lighter one to encourage the cuff to switch on.
I never use anything above a red.
No, neither do I. And then just if, like, for example, if you found that the scapular assistance test was the main improvement test that helped their pain, I would use that to guide my treatment. So what you may do is get like a TheraBand round the back of the scapula to give them that sensory feedback on the scapula. And then you can do, for example, if they're lying down on their back, you could just do like your kind of punches. So and with the band wrapped around the back of the fist, so you're still getting that posterior cuff activation, but you're getting the feedback on the scapula as well. So these are some examples: lying on your side, punching up. There's quite a few things that you can do, but yeah. And then just
So what I'd like people to do actually is just in the chat. So just thinking about the next seminar, it's going to be face to face, much more practical. So hopefully some of these things are just a good refresher. You know, I wouldn't be surprised if it's just confirming that you're doing the right things already. But it'd be really useful just if you can put in the chat any specific things that you'd like us to cover or do in more detail, and also perhaps relate it to the patients that you see, because obviously we don't really know. There's people from various parts of neuro, so I'm sure you've all got different challenges, so it'd be really useful for us to guide the next session. So if you can put that in the chat, that'd be great. An hour and a half wasn't long to get all of this into, so shoulder instability is pretty brief at the minute, intentionally. So instability, it's a name bandied around quite a lot and probably misused a little bit. So what is the difference between instability and laxity? Does anyone know? I can't see the chat, so I've got no idea if anyone's answering. Go on, can anyone speak up or not? Are you muted? Okay, I'll do the work for you then. Laxity is excess movement without symptoms. Instability is excess movement with symptoms. So just because you're lax doesn't mean it's a problem. Some people function well as an elastic band. Other people don't. So you really got to ask yourself, is it a problem or not? And should I interfere with it or not? Because some people just happily plodding along being really bendy. The Stanmore triangle also recognises that, so we'll come on to that in a second. But in terms of instability, so many years ago when I did a neuro rotation, I remember stroke patients with, you know, subluxed shoulders. It was a long way in the past, so my memory's not too clear, but I know these are things that people come across commonly. So repeated dislocations are common of an unstable shoulder. You can have instability that presents as rotator cuff related pain, and it's just been misdiagnosed. They might have a persistent sensation that the shoulder's going to come out of joint. Some people just then adapt to it and then don't and avoid those movements, and then probably then become a bit stiffer. Clicking and catching is also something that can be found with it. You need to be quite skeptical of that, because a lot of people have clicking and catching, but then when you actually ask them what they mean by it, they don't mean clicking or catching at all. But it certainly can happen, and that's often associated with labral tears as well. And then the types of dislocation / instability. So we've got anterior, posterior and inferior here. We've missed off multi-directional, but that also does exist. So posterior dislocations are more common with epileptics. The anterior dislocation is the most common, and inferior, again, much more unusual, but Lucy's seen a posterior and inferior recently. I think the inferior was a arm trapped and they fell. So yeah, all very different. The most common by far is anterior. So the Stanmore triangle, I don't know if people are familiar with this. This is a classification for shoulder instability. So you've got your type 1, which is structural and traumatic. So, you know, a rugby dislocation, clear precipitating injury, got wrenched out of joint. Probably the person tried to put it back in themselves, which isn't a great idea. So you then got the type 2, which is the atraumatic structural, and a lot of these are repetitive things where, so say you got a type 2 anterior instability, that head of the humerus has just been pushing forward and it's gradually stretching that capsule, and the capsule's getting saggier and saggier, and there's more and more movement. So that's that kind of developing picture. Then the third one, you've got muscle patterning, which is non-structural. So these are the those patients that come in and say, oh, I pop my shoulder out at a party, you know, I do it as a to get attention. I do actually think a lot of them have a lot of psychosocial aspects to their problem as well. But what they found is that they stabilized a lot of these type 3s many years ago, probably 20 odd years ago, and then they all went to the main instability hospital down near London, and they started having to reverse all of the procedures because it was just making it worse. And they realized that actually for this muscle patterning non-structural, so we shouldn't interfere surgically with them, and they do have good outcomes conservatively. So if a shoulder comes out of joint, it's going to go over the labrum. The labrum basically deepens your socket. I look at it as a clock face. So there's 3 types of labral tear. You've got your slap tear, which is your superior labral anterior to posterior. That's why it's called slap. And that happens between 10 o'clock and 2 o'clock. You then got your Bankart lesions, which are basically from 2 o'clock to 6 o'clock. And they happen with anterior dislocations often. And then you've got your reverse Bankart, which is from 6 o'clock to 10 o'clock. Often you find that these tears go from one zone to another. Slap lesions have different gradings depending on if it's a bucket handle or not, etc. That's often not associated with instability, but certainly the Bankart and reverse Bankart are. The other function of the labrum, apart from deepening the socket, is it's an attachment for the capsule. So why does the capsule matter? Well, it's got the tendons merged, it's got the ligaments merged, it's got the capsule itself. So it all functions as one, and it provides feedback to your brain. So, you know, you've got that, your stretch receptors, you've got your afferent feedback, and basically when you start moving, it then fires messages to your brain. Your brain says, right, activate this, and it controls your shoulder. So if you then make that really lax, you stop getting all of that feedback, and then the activation doesn't happen, and therefore you have more instability. So you can move things from being unstable to being lax, and then just have better control. And some studies have shown that proprioception can play an important role in joint stability.
So instability tests, we were thinking of maybe covering this more in the second session, because it's quite difficult to kind of cover that just sitting down. But the main tests for instability are your apprehension test, where you basically take the patient in supine up into kind of abduction, and you basically start to externally rotate, and then they will usually get to a point where they don't feel safe, or they feel a bit apprehensive, and then you would then basically use the palm of your hand to kind of apply an AP to the humeral head to kind of relocate, and then you can usually take them a little bit further back and they feel more secure. So that would be like a positive test for apprehension relocation. And then you've all probably heard of the sulcus sign, where you basically just kind of put your thumb and fingers here and then just kind of pull down on the arm, and there may be a gap there. Yeah.
We'll go over
Yeah.
these at the next session.
Yeah. And then just quickly to run over treatment. So there's a few treatment programs. The main two that I generally tend to use is the Derby Shoulder Instability Program. I tend to use these for the traumatic dislocator, so the polar type ones. This focuses on proprioceptive deficits. I'll show you in a second. And then the Watson Multidirectional Instability Program is for your non-traumatic patients with general laxity, so your polar type 2 and 3s. And this focuses on retraining and maintaining the scapular and humeral head control before strengthening. They looked at a study where they compared them both, and the Derby Instability Program they found was best, as it required less treatment and patients got better. But I think it depends on your patient, if I'm being honest. So I've left the link here so you can have a little read of the Watson program if needed, because it is quite lengthy. There's 2 papers on it. So this is just that I've just took a screenshot of like the starting kind of exercises. So there's a scapular phase that aims to like develop the scapular stability to centralize the humeral head, and then gain control from 0 to 45 degrees of abduction. So we start basically holding a small weight, working on kind of retracting that shoulder, and then we can progress that with TheraBand. But I'll let you have a little read of that in your own time.
Yeah, so the link is there and you'll get a copy of this presentation.
Yeah. And then the last one is Derby Instability. So I use this quite a lot with my dislocated patients. So this is split into 2 sections. So section 1 is more on like the speed of muscle activation. And then the second stage is more like your proprioceptive exercises. So again, if you're just typing on Google Derby Instability Program, it's easily available, and you'd give a patient 1 exercise from each section to do twice a day. To kind of work through that, and as each time you review them, I just kind of progress down this program to make the exercises a bit more challenging. Yeah. So general treatment options for shoulders, as we've kind of covered throughout this, is the postural awareness, getting glutes and abs activated in your shoulder rehab. This will help to reduce inhibition basically reduce overactivity of like your lats and levator scap, and make sure we're activating the muscles that we want to work. We can use more like passive treatments as well, like soft tissue release and K-taping, but a manual therapy. But it's just important that we don't use them as a standalone treatment. They must be with a comprehensive physio program.
Yeah, and then the assessment algorithm is, first stop, exclude stiffness. If it is stiff, why? So frozen shoulder, OA, or it could be a collapse from AVN, or it could be a primary, secondary tumour, etc. If there's no stiffness, then test the cuff. Think about optimal positioning for testing that we went through based on the EMG studies. If it is weak, then why is it weak? Is it because of a neurological reason, so the muscle not getting the message, or is it because of the tendon integrity? If there's no weakness or restriction, is there instability or laxity? And then you can then move on to do your improvement tests and use that to guide your rehab, and think about the normal movement of the scapula and the shoulder, and if you add in those things, strengthen those muscles, and that makes it really simple. And if you're stuck, just give them a posterior cuff facilitation and a serratus anterior exercise, and I suspect they will get a little bit better.
So does anyone have any questions?
Yeah, just thinking about patients that have a completely dense, weak upper limb, they can't do any active movement at all. We have a lot of patients where we have real issues with pain, and they literally don't want you to touch them at all or move their arm at all. So you end up having to just think about sort of positioning and stabilising the arm. Have you got any other ideas or suggestions that we could do in that situation?
Without more details, it's difficult, but so I get the feeling you're starting to talk about, you know, is that pain neuropathic? So for chronic shoulder pains that are often recalcitrant to some treatments, there is a consideration of nerve block, if that's what you're talking about. Is that what you're talking about?
Yeah, there's definitely an element of neuropathic pain involved, yeah.
Yeah, so nerve blocks have shown to have some benefit. It's quite a difficult thing to just answer generically, but if they're not moving it and it's very painful, and it sounded from your description that there was a lot of neuropathic element to it in terms of hyperalgesia, then you're probably looking at more controlling the pain from the nerve,
Yeah.
I'd suggest. Yeah,
it's a very vicious cycle, because obviously as soon as they can't move it, you then get all the kind of secondary effect of the stiffness.
Yeah. Would they, pardon my ignorance, so with these patients, so it's just the prognosis for them moving that is not good, I presume. So
yeah, so sometimes we have patients where they're not likely to get much movement back, but sometimes there definitely is potential for getting some movement back, but because of the pain, it's very difficult to access that
right,
sort of improving activity.
Yeah, so I mean, who would do your injections?
So we've
the consultants in your rehab do them, and all our trainees do them.
Yeah.
Okay. Yeah, it's part of our training. Yeah, so we do suprascapular nerve blocks.
Yeah.
Yeah, but one of the difficulties is you also get mechanical problems, because these are often flaccid, heavy limbs, and so you get traction on the rotator cuff and often sort of subluxation at the shoulder. So it's a combination of mechanical and neuropathic pain.
Yeah, real challenge, isn't it?
Yeah.
Do they do well with the nerve block?
Yeah, I mean, for reasons that nobody understands, they can last for 3 months, but sometimes you have to do them every week.
Wow. Okay.
Yeah, there's one unit in Stoke where they used to, one of their junior doctors used to go around and do all the Guillain-Barré patients suprascapular nerve blocks every week. But in most of our patients, they'll last 2 to 3 months.
And then what does that then enable you to do? So I always look at
it means the patient's pain-free.
Yeah, I know that.
Yeah.
What I mean is that's your window. So you're using that to then enable you to do something to put them into a better position before that block runs out.
Yeah, to get in and get some going and some activity going.
And
but also if they're having a lot of pain, they're not able to engage in their other aspects of rehabilitation.
Yeah, exactly. So that's your window, and then hopefully if you can then improve that through you know, some of the things that we've discussed, various depending on the cause, then you might find that those blocks are required less frequently.
Yeah. You know, I have a number of patients who come to outpatients and have them every 3 months or so. Yeah, because they've got chronic problems and they just find them helpful. Yeah, you don't know whether it's a placebo response, but you know, bupivacaine's cheap and it doesn't do any harm.
Yeah, and who wants really severe shoulder pain as well? Yeah,
Absolutely.
Yeah. So in terms of you know, the next session, I mean, we're aware that was quite basic. We're also aware it's very MSK, but that's what we do. So we're no experts in neuro. Anything that we could do or focus on, or that you'd find really useful for the next session?
I think kind of touching on that previous comment about sort of post-stroke shoulder pain in particular, and that context of more global weakness, when actually, so potentially how to modify some of those tests and further practice with the scapular humeral rhythm as well, because that's an often problem, the scapula getting really tight, really, really stiff. So how to sort of loosen that up when actually there's a lot of global weakness in the picture as well. I think that's the difficulty, so have to modify things for that patient population would be quite interesting. And in the context of pain and how much, it's difficult, isn't it, with the pain, if it's not neuropathic and if it's more musculoskeletal, how much we're wanting to sort of push into that pain with particular treatment as well would be quite useful, because I feel like from a neuro perspective, I'm a little bit more worried and more cautious, I'd say, less rather than worried about how much to push some of those treatment options from lacking MSK experience. That was a waffly answer, but
yeah, no, that's good. Yeah, and so probably then, so we get a lot of you know, massive rotator cuff tears that are inoperable, and they actually do really well with rehab. So maybe that going through that kind of deltoid retraining program for shoulders without functioning cuffs, maybe that might be useful then as well.
Yeah, another thing that I work in the community, so I'll see stroke patients a little bit further down the line. If the shoulder has been a lower priority for them, the scapula can get really, really stiff, and I find it incredibly difficult to loosen up around that area with sort of manual techniques or passively or actively. So again, that recently we're trying to work with a chap at the moment where I'm not really getting anywhere, and that's obviously impacting the rest of his upper limb shoulder movement. So again, any ways to think about that would be really useful too.
Yeah, thanks for that feedback, it's really useful. Anyone else got any requests? No. Okay.
Well, thank you very much, both of you. Thank you for putting in all the work. Thank you, everybody, for attending. And just, I think it was an excellent presentation. Lots to think about.